Good morning, ladies and gentlemen. We have a busy day today, so we have to start sharp. And the first will be a series of lectures, some of them pre-recorded, some of them will be in live here. And then after break, we will have another series of live cases. So and there will be these new technologies like pulse field again. So very exciting program. So let's start with the first presentation, which is by Jakob Koruth from New York, and it's about it's a general talk about pulse field ablation, about tissue selectivity, and it's pre-recorded.
Hello, everyone. My topic for today is to talk about the unique tissue selectivity of PFA. These are my disclosures, and I'd like to thank Dr. Kotzner and the organizing committee for yet again an invitation for me to be part of this lovely meeting. It is truly an honor and pleasure to be with all of you today. So let's get started. The words that I'm going to concentrate for this talk is going to be selectivity and PFA. Now remember, PFA exists in this wide zone of irreversible electroporation. But for different catheters and different pulse sequences, if you encroach upon the thermal properties of electricity, it'll no longer be PFA, and that should not be synonymous as it not being selective. So for every technology out there, we need to establish that it's truly within the world of irreversible IRE. Moreover, talking about selectivity, when you look at all the data that's been accumulated through preclinical and bench research, this summary slide that was initially shared as part of the initial clinical paper by Dr. Reddy and Dr. Neužil and Dr. Jays and ourselves, when you look at this slide set, you get the sense that there is a big difference between myocardial sensitivity and other cells, as well as nervous tissue. And the point that needs to be made based on this figure is that this was preclinical data using different pulses, different durations, maybe even different waveforms. So while there was an early suggestion that there was selectivity, there's more to the story. Another point that you need to keep in mind is that, forgetting selectivity for a second, PFA as an ablation source has been consistently described based on gross and histology as an ablation source that does not disrupt the tissue scaffolding of an organ that is either being ablated or in the adjacent areas. And this is very different from thermal burns. So keep that in mind as you think about PFA and how it's different. This is just a good visual for you to appreciate the difference in homogeneous fibrosis with PFA and the differences with RF lesions. This will sort of set the stage as I take you through sensitivity data for different organ tissues. Before we delve into specific tissues, I'm going to refer you to this nice study by Dr. Hunt and Tandri, where you're using monolayer preparations of rat ventricular myocytes, smooth muscle cells, and cortical neurons. And when you look at the same shock energies being applied, you see a selectivity. A lot of the ventricular myocytes are ablated and much less for smooth muscle cells and cortical neurons. Note, they are not resistant to ablation, but there's a difference. And when you pull away from the energy source, the difference between myocytes and smooth muscle cells is somewhat exaggerated. And this suggests that there is truly a tissue specificity. There is conflicting data, though. People have published similar monolayer preparations looking at atrial myocytes and nervous tissue most similar to peripheral nerves, and have said that they are almost equivalently ablatable. But that, again, is not reflective of what we experience clinically, where we have long axons, which are the nerves that we are talking about. So let's take us one by one as to what we have with nervous tissue. We know from preclinical studies from the Wittkamp group in 2015 and from our group that despite large lesions in the SVC, the phrenic nerve was spared both acutely and chronically. We have lots of examples of complete fibrosis with preserved nerve fascicles right in the middle of the scar, suggesting that nerves definitely seem to be somewhat resistant to PFA. The clinical data from Dr. Reddy, Dr. Jace, and Dr. Neužil telling us that from the multi-electrode catheter experience, there were no episodes of paresis or palsy in these patients. However, with ongoing clinical experience, we have now appreciated that transient paresis can occur. Now, these are very short duration episodes, but is it possible that you can get longer duration paresis? Is it possible that you get permanent paresis, especially given that we're not ablating atop the phrenic nerve? It's possible, but the majority of data seems very optimistic that our ability to permanently damage the nerve at the doses that need to ablate mitral tissue is going to be unlikely. A few seconds about epicardial ganglia, a relevant topic. We know we can activate epicardial ganglia during PFA and cause repeated episodes of bradycardia, which has raised the question as to whether we stimulate, ablate, or both. And I think more data needs to be presented before we conclusively can understand how endocardial or epicardial PFA behaves differently for ganglia. What about venous stenosis? In the interest of time, I'm not going to talk about the preclinical data that seems very clear that there is no chronic venous stenosis. You may get some acute narrowing from edema, particularly in the animal models, but more recent data from Dr. Kuroki and Vivek and Petr suggests that when you compare PFA versus RFA in red and PFA in purple, there's really no evidence of venous stenosis with PFA. And I think the bulk of data that we have is that thoracic veins do not lead to a stenotic response with PFA. And I think this is going to be a class effect that we'll see with other types of PFA, as long as we establish where in that zone of ablation they exist. More importantly, the esophagus, something that we're all worried about. The Wittkamp group did the initial open surgical direct application of PFA and said the majority of the time the esophagus was spared. They saw some transient mucosal lesions and some very small muscularis lesions, but mostly preserved. Our data that I'll show you in the next slide said the same thing. But more compelling evidence from the clinical cases come from the group from Bordeaux, where they demonstrate that with cryo and RF, you get esophageal wall enhancement. And despite the remarkable enhancement that we see with PFA on the myocardium, we see nothing on the esophagus, which is very compelling evidence that there seems to be a strong suggestion that PFA at the doses with this catheter spares the esophageal tissue. This is data from our model where we forcefully deviate the esophagus onto the IVC and create these big lesions with radiofrequency, but completely preserved tissue with PFA with the multi-electrode catheter that we just talked about. Again, clinical experience cumulatively from the multi-electrode catheter studies, we have esophageal findings on EGD and CMR, about 50 patients showing no lesions. And I'm increasingly convinced that despite the fact that at some dose you may be able to ablate smooth muscle cells and mucosal cells of the esophagus, the fistulizing response of thermal injuries will not be replicated in the esophagus for PFA as we know it today. Time will tell. Arteries, another very important concept. Early data, again, from the group from Wittkamp, Dupre, Kars-Nevins, who demonstrated that you can get transient spasm when you apply these monophasic pulses epicardially, but you could be surrounded by these huge lesions and have complete sparing of the LAD. They did notice some cases of intimal hyperplasia, but these are 3-month studies. We need longer studies to be very confident, but in general, there is no chronic damage to these large coronary arteries. We replicated the venous experience in the coronary sinus, showing no narrowing, just ablation of tissue. And this example of ventricular scar with preserved arteries right in the middle of it with some medial hypertrophy, again suggests that in general vessels could be spared, so rather are spared. But let's go a step further. This case report has gained a lot of attention. This is from Dr. Gunawardene and Dr. Willems, suggesting that in this particular case where they applied a mitral PFA lesion, they caused spasm of the circumflex, and then that got better. So this is certainly a one event. It is likely common to all PFA. Whether this is a local effect or activation of sympathetics, we don't know. We have seen the same thing with focal catheters endocardially. This is an example of a long segment spasm in a swine model. And I think this is an important aspect of PFA that needs to be understood better, how you best treat it, and what are the situations where this is going to be common. So there is an effect here that may have more to do with smooth muscle cell activation. A few words on PFA on the epicardium. Note these epicardial lesions that hopefully we'll get to share with you with our upcoming publication. You can see how the epicardial surface has not been disrupted. You can even trace out the veins here with spared lumen despite ablation all around it. And look at the fat. We've had data suggesting that PFA causes minimal inflammation of the fat, and you see a lesion atop the fat. There's no disruption on the fat acutely. And you can see some extension of the PFA even below the fat, suggesting that it's not a permanent barrier. Again, artery, fat, nerve completely preserved in these acute epicardial PF lesions that we created. Lastly, I want to take a moment to talk about the interaction of PFA with scar, which we need to understand well when we're trying to understand how PFA will interact with collagenous tissue in the heart and outside the heart. And in this experiment, we created a big lesion of PFA, let it mature, and then go back 4 weeks later and place PF lesions on the border of the scar, suggesting that if scar or collagen was a barrier, we would not get any lesion under the scar, but in the border where there was no scar, you would get a deep lesion. What did we find? The dark area is a chronic scar, and the acute lesion that we placed 4 weeks later shows that not only does it get to similar depths on the periphery or the border of the scar, you can get penetration deep under this mature, homogeneous 4-week swine scar. Not the scar that we see in a 20-year-old infarct, but at least telling us how pulse field interacts with collagenous tissue. So in summary, I would like to think of PFA and selectivity very carefully. We know from early preclinical and clinical experience that there seems to be a preferential ablation of myocardium without us having to pay the usual penalty that we've paid for collateral tissues. So I would say it is fair to say there appears to be a proportional selectivity in comparison to other sources. This selectivity depends on the distance from the tissue and the dose applied, suggesting, in other words, that if you can ablate intestines and pancreas and prostate with PFA, there is no magic, complete lack of sensitivity of all tissues to PFA. At some dose, at some proximity, we may be able to create lesions, but as far as we're concerned, making atrial lesions in the thin wall atrium, there seems to be a proportional selectivity. We have to remember that we need to ensure that there are no thermal effects, that we understand that this may be specific to every catheter, every dose, every pulse design. And lastly, when it comes to fistulas, remember PFA quite clearly seems to demonstrate that scaffolding and collagen structure of the organ is preserved. With that, I'll end and thank you.
Discussion will be at the end of this session, and it's my pleasure to invite My co-chair, Hiroshi Nakagawa, you know him quite well from previous editions and also from his very important papers on different energies. And Hiroshi will talk about pulse field ablation in the atrium, what we can expect and what are the results of current studies. So please, Hiroshi.
Okay, can I have my slide? All right, thank you, Professor Karsner. And thank you again, the kind invitation to be here. So here's a Cleveland Clinic. I talk about the pulse electric field ablation in the atrium. My disclosure shown here. Let's talk about the mechanism of the cell injury to the pulse electric field or PF application. So applying the pulse electric field application, very high voltage, resulting in the increased membrane permeability in the myocyte. Some literature showing even physically you make the poration on the membrane. So therefore, the very easy disturb the ionic channel, producing the like an unexcited myocyte, i.e. conduction block. But the unique stuff for the PF application, actually membrane repair. That's a very unique. And then the people doing the gene therapy, so transfer gene into the myocyte, but not destroying the cell. So actually the back to the viable myocyte. That's indicating a transient conduction block for us. That's maybe a problem. I want to focus that issue for today talk. If you increase in the the strength of the pulse field, and like membrane permeability poration increase further, and then ATP depletion or leakage. So then mitochondrial activity will be enhanced to compensate the ATP depletion, but it's still viable. All right. And the further increase, then now finally the damaging mitochondria are resulting in the irreversible lesion or permanent block, actually primarily due to the progression of the apoptosis or programmed cell death. If further increase strength, now cell membrane rupture, tremendous calcium influx to the myocyte, resulting in the contraction band necrosis, and also increasing microvascular permeability, so starting the hemorrhage and swelling. It is complicated compared to the RF lesion formation. So this is like a surgical ablation device, like a bipolar clamping, and RF energy. We know the acute lesion showing the coagulation necrosis, i.e. thermal injury. In contrast, the PF application, no coagulation necrosis, because not thermal injury. But you see the contraction band necrosis, a lot of red blood cell, and also interstitial space increase because they increase the microvascular permeability. That started like usually 2 hours after the ablation. But importantly, complete different appearance compared to RF, coagulation necrosis, thermal injury, compared to the no coagulation necrosis because no thermal injury. But acutely, you see the contraction band necrosis and the hemorrhage swelling. Okay. So then, increasing the strength of the pulse field and the pulse duration. You can start in a reversible electroporation that initiate the gene therapy. If you increase further, then you can make the irreversible lesion formation. That's we like to have the EP ablation. But you cannot skip the reversible zone. If you increase further, then eventually you produce a thermal injury, which also we don't want to have it to avoid the collateral damage. So then it's complicated. Again, the factors affecting the ablation lesion size for the PEF ablation, the pulse strength, pulse shape, frequency, polarity, number of pulse, duration, even the fiber orientation may affect the lesion formation. It's complicated. So this the basic study using like 2 microseconds and 50 cycles each burst. Increased number of bursts up to the 60 ablation lesion volume increase, then became plateau. And if you're talking about the lethal threshold, that's actually the decrease up to the 60, of the burst pulse. So in summary, for selective PEF energy waveform, ablation lesion volume after the success PEF application shows a non-linear behavior, but reaching the plateau. In order to maximize the ablation lesion volume while preventing thermal injury, the total PEF energy is fragmented, pulsed, and delivered during the refractory period of the consecutive cardiac cycle to prevent the ventricular arrhythmias. Let's switch the gear. Effect of the electrode tissue contact force and the PEF ablation lesion size. As we know, during the RF ablation, lesion size, incidence stim pop increase with increasing contact force, RF power, and application time. That's the reason I invented the horsepower time index formula or ablation index with the biosense website people like a long time ago. Now became the world standard, right? I'm sure everybody using, I hope, each case for the ablation, RF ablation. In contrast to RF, it has been reported that PF does not require electrode contact to achieve effective ablation lesions. However, the effective electrode tissue contact on the lesion formation for the PF ablation has not been well validated. So therefore, we would like to test it to whether the requirement electrode contact and the relationship, the average contact force and the lesion size for the PF ablation using the beating swine heart model. So this is one of the generator manufactured by the Galaxy Medical Centauri. So biphasic, microsecond scale, and they're using the monopolar delivery electrode and the skin patch, and of course selective dose. Advanced this system, you can use any focal RF catheter, even with contact force sensor. This study is performed using the TAC catheter Abbott 7-inch, the 4mm tip, and the contact force sensor. The protocol is simple. A closed chest swine, right ventricle, 20 amp constant, and synchronized 4 QRS, and the variable is contact force like a low, moderate, high, like a 10-gram range, 20-gram range, 40-gram range, while applying a constant PF application. Importantly, we did a non-contact ablation, confirmed by the contact force tracing also into cardiac echo, like 1 or 2 millimeter away from endocardium. For left ventricle, increasing the current up to 35 amps, and the synchronized 7 QRS. Again, low, moderate, high contact force, no contact. Here's the inside velocity map. Here's the left ventricle voltage map. And this particular ablation was like 11 gram average contact force ablate there. Okay? Right, it was 35 amps. Okay, and here's the confirming the contact, not only contact force sensor catheter, as shown here. During the PF application, we don't see any microbubble formation, which is good for this system. And intentionally, 2 millimeter away from endocardium, whether we can make an effective lesion or not, okay? And then to assess the acute lesion, we need a special staining. So 2 hours after the PF application, triphenyl tetrazone chloride, TTC, was administered intravenously. TTC stained the mitochondrial enzyme of succinate dehydrogenase of the living cell, red color, and distinguished the viable, it's red, stained red, and necrosis pale tissue. Okay. And also very complicated staining, the Cox staining was also performed, examining the respiratory enzyme of the mitochondria. All right, that's the related to the mitochondrial activity to delineate reversible or irreversible zone, and also conventional histological examination, H&D, and trichome staining. Here's the LV ablation. This is cross-section. This is TTC staining. So this is endocardium, epicardium. It's not transmural lesion. Central zone is dark, and they are surrounded by the pale zone. Pale means no TTC staining, no mitochondrial activity indicating going to die. All right, this is the apoptosis zone. Central dark zone, I presented this data last year at HLS. Some reason, people only knows RF As soon as you see dark zone, people say, oh, this is the CHA. You're making the high tissue temperature. Make a long story short. Oh, anyway, lesion depth is measured from here to here. As I mentioned, the pulse field application resulting the increased microvascular permeability resulting the leakage red blood cell hemorrhage. I'll show the histology later. Make a long story short, it's not CHA, period. Okay? And then this is the data, relationship, the average contact force versus lesion depth. So the RB ablation, 28 amps, increasing contact force, lesion depth increase non-linearly. Left ventricular ablation, higher the current, increasing contact force from like a 5 gram up to the 40, 50 gram, significant increase non-linearly. The slope is different, depends on the how high for the PF current. Importantly, 1 or 2 millimeters away from endocardial, no lesion was detected. All right, and then this is data showing the my friend Fred Whitcomb published the SAC-EP 2014. So the epicardial pulse field ablation, his generator is different, but the fundamental physics is same. Single catheter, 200 joules, no arcing, and then ablate there. It's very simple. Epicardial space, ablate. All right, this is 7 hours after the ablation, epicardially. You see here, hemorrhage. And then he didn't show the necrosis, the histology acutely, but I'm very positive the contraction band necrosis. 3 months later, the replacement of fibrosis. But important to look at the lesion depth. Single dose looks like the epicardial space more likely have some electro tissue contact, but the lesion depth, like average 6.4 millimeter, however, range 0 to 10.4 millimeter, quite wide range, suggesting the electro tissue coupling or contact force is important for the PF application, epicardial application as well. This is not the myocardium. This is a famous liver swine study, radiology published in 2013. This group doing the cancer therapy. This is a bipolar pulse field application of electrodes here, like a sandwich of the liver, and they're measuring the liver temperature between. All right, simple experiment. Not myocardium, however, look at here. So the constant voltage to 2900 voltage, but the increasing pulse width study up to 100 microseconds. Increasing a pulse width, you see the liver temperature between like 40 degrees and increasing up to 65 by increasing the pulse width. And this is acute region formation. This is lower one is very dark, and the very high temperature, it's not dark zone. All right? And then this is actually I showed the histology, coagulation necrosis, because the tissue temperature more than 50 degrees or 65. Coagulation necrosis, thermal injury, period. For this one, 40 degrees, it's no way to make the thermal injury or coagulation necrosis. Essentially, this one, the thermal injury, actually, the dark zone is actually the red blood cell infiltration, showing the next slide. You see? Hemorrhage. Again, because the microvascular permeability increase, so leaking red blood cell, and also the interstitial space is increased. So it's also indicating edema. But they double-check the heat shocks, protein stability staining, no staining. So therefore, no heat injury, and also the very complicated staining, the cast-paste staining indicating the extensive apoptosis activities initiated, as expected. If you go the longer pulse, tissue temperature 65, coagulation necrosis, no dark zone, all right, because microvascular is already occluded, no leakage hemorrhage acutely, and the heat shock proteins is stained, definitely thermal injury. No apoptosis because already dead. All right, it's different. All right, go back to the left ventricular region. Central dark zone, if you go to the H-end staining, destruction of the myocyte architecture with a contraction band necrosis, all right, and the nuclear epicnosis indicating acute necrosis, as well as the hemorrhage, you see red blood cell, all right, because and also increased interstitial space. resulting from the increased the microvascular permeability, right? Pulse field ablation increased membrane permeability, not only myocyte, as well the microvascular structures. Pale zone, histologically, you don't see much the change. It's not necrosis, very minimal nuclear pyknosis, but no TTC staining. No mitochondrial enzyme activity, essentially, this cell going to the apoptosis. After here's irreversible zone. But you see here, if you take a look at here, this is called hyperstain zone. And histologically, totally normal. Remember, the increased membrane permeability, ATP leakage. So therefore, as long as the mitochondria is active, they try to activity enhance to compensate the ATP depletion, making more ATP more. So that zone's more likely reversible zone. This is very complicated. This doesn't happen for the RF ablation. And then Cox staining, again, the respiratory enzyme. For the pale zone, no staining, no mitochondrial activity indicating the apoptosis zone. Hyperstain limb for the TTC, and the Cox stain also hyperstain. So again, PF application result in the leakage of the intercellular ATP due to increased membrane permeability. So therefore, the mitochondrial activity enhanced to compensate the ATP depletion. But this zone is not dead. It's more likely reversible, but the transient conduction block zone, because membrane permeability already changed. It's no way to maintain the normal action potential, i.e. transient conduction block or reversible zone. And then if pale zone, if you wait 14 days, this pale zone, I don't see any more hyperstain zone, only simple the pale zone and the trichome staining showing the replacement fibrosis. Compared to RF, yes, it is in 2 weeks, very rapid healing process because microvascular, it's the perfusion is preserved, so therefore healing process even quicker. But the hyperstain limb. So therefore, in summary, like here, this is a famous publication, Jack, 1995. My friend with Kamp and De Backer, a Dutch group, they're doing I think lung endoperfusion heart. To get a permanent conduction block for the RF ablation, tissue temperature minimum up to 51.7 degrees, permanent conduction block. However, transient conduction block occurred at temperature 49.5. It's very close, indicating the reverse zone, it's not very broad. However, PF, if you want to make the similar irreversible, the permanent conduction zone, but they are surrounded by relatively broad transient or reversible zone in PF application. This is an atrial point-by-point linear ablation, the swine model linear lesion here. Like 1 hour after ablation, it's low voltage area, less than 0.10 millivolt, very broad. 2 weeks later, low voltage area shrink, but more importantly, conduction came back. This is indicating the relatively wide reverse zone associated with PF application. If you're talking about a clinical case, this is like a lasso type or like a circular type. It's not lasso, like a circular type catheter in patient in proximal fibrillation in the Cleveland Clinic. And then, first PF application, all potential gone. But very impressive, all right? And then protocol like a full consecutive energy application. You waited 1 hour. Potential never come back. Is it good news or bad news? How would you know like a circular catheter, any configurations, very unlikely you have a circumferential contact, right? Because geometry doesn't fit. But the PV isolation, the definition is no PV potential without electrical contact. Like I presented, doesn't make sense. What's going on here? And then this is the Pfa system, this lattice electrode. I think we have a live case today, right? Yeah, it would be nice. And the 9mm lattice electrode, we have a 9 surface recording electrode. And then they can do the RF application as well as the PF application. talking about the PF application like RF current 24 up to 32 amps and the biphasic microsecond application similar to other generator. So this is one of the case the Josephs and the Peter, Parkway performed, and I partially participated in this one as well. This is the ablation tag point by point, like a diameter 7 millimeter, and they're connecting. Even though the Elad select 9 millimeter, tremendous overlap. If you're starting here, you click ambient potential. If you go next spot, never ablate, new spot, but no potential already, indicating a much broader area affected. But doesn't mean the irreversible lesion formation. And this is the case, I like this, again, this is the ICAM case, Joseph and Peter and Eva doing over there. There's small macro entry nicely. And then this is arrhythmogenic channel, 3 centimeter in diameter. It's no narrow channel. First PF and second PF, after second PF, nicely terminate, but eliminate potential entire channel without ablation. Then we extended up to here. It's about the extending PF application after electron elimination to taking care of the like a reversible standard myocardium zone. So in summary, during a PF ablation, electrode tissue contact is required for the effective lesion formation. At same PF dose intensity, lesion depth increase significantly with increasing contact force. Acute PF ablation lesions are well demarcated with a TTC staining, showing the dark central zone surrounded by the pale zone. Oh, I missed the pale zone here, sorry. And confirmed by the histology, especially dark zone is a contraction band necrosis, nuclear pycnosis, and hemorrhage. At hyperstain leaf in the TTC staining beyond the pale zone indicate the enhanced mitochondrial activity, suggesting a possible reversible zone. Again, the enhanced activity of Cox staining extended unaffected the myocardium, again, consistent with possible reversible zone. Large area of electron elimination after PF application, AF patient suggests that the PF ablation is associated with a broad reversible zone. Future study, of course, are required to examine the relationship with the cellular electrophysiology and the histochemical observations. Thank you. So the next speaker from the Dr. Elad Ante, Pulse ablation in ventricle. It's listed in Cleveland. I think he is not in Cleveland anymore, but I believe he went back to Israel. Okay, thank you.
Okay. Is this working? Can you hear me? Yeah? Okay, hi everyone. So let me just start. Okay, so I'm going to speak about what we know about PFA in the ventricle, and including new data about how PFA affects in scar tissue in a post-infarction model. So the question, pulse field ablation has obvious advantages for AFib ablation, right? Like, we spare the phrenic nerve, we don't risk the esophagus, and that's the whole promise about PFA. But once you have a new energy, the question becomes, is it really helpful for ablation in the ventricle? And what are the utilities of this? Are there limitations? Is radiofrequency going away for the ventricle or not? And I'll try to show you what are the, from what we know so far, what are the potential advantages, what are the limitations, and what's the current state. So RF ablation is still the most common energy when we are ablating particularly scar-related ventricular tachycardias. But there are limitations of RFA, as you witnessed yesterday in a Pierre case. A lot of lesions, not all of them are effective. So we know that when we apply RFA not in healthy tissue, but particularly in scar tissue, in heterogeneous scar tissue, that results in shallower lesions compared to healthy tissue. And this is one of my fellows published a few years ago. On the top panel here, you can see how energy is being distributed in a healthy, homogeneous myocardium. And that results in a predictable lesion size. And you can use ablation index and, just like common sense of power and duration to predict what's going to be your lesion. But you cannot do the same thing. You can infer data from healthy tissue to scar tissue. And we had examined the effect of RFA in scar, and it was very interesting. We gave it to a very famous pathologist, cardiac pathologist, and told him, can you show us where the lesions that we made here with the thermocool catheter, 40 watts, 50 seconds, 90 seconds. He called me, that was a few years ago, he said, this tissue was not ablated. And I said, absolutely was ablated. We repeated this in multiple swine, and we realized that ablation in scar doesn't leave the same well-demarcated lesions. And the reason being is that, and we modeled this in multiple ways, is that collagen and fat really interfere with the way that energy goes with RF. So collagen results in is a thermal barrier. So there's no conduction, or there is less conduction of heat past collagen. And the second thing is that fat acts as a capacitor for heat. So what happens is that instead of homogeneous transfer of heat, you have a very inhomogeneous transfer of heat. And that leads to, again, not only shallow lesions, but non-predictable effect. And the architecture of the lesion is very disrupted. You can see areas that, just under the catheter that are not ablated, but on the other hand, areas that are far distal that are ablated. So it's very hard to predict what RF does in scar. It requires relatively long applications, particularly compared to PFA, which is microseconds. There is potential injury to coronary arteries and nerves. And you have to put multiple lesions. You saw the case yesterday that ended very late at night. And that all of this may explain why we have a high recurrence rate in VTs. It could be that the mapping mapping is still not very specific. So the specificity of mapping is limited, but I think a major reason for failures are ineffective energy delivery. Now, pulse field ablation is rapid, non-thermal or minimally thermal, and it has high selectivity for myocardial tissue in comparison to RFA, so obviously it's something we need to evaluate also for the ventricle. I'm not going to go over this too much, but I think all of you are aware nowadays how pulse field ablation, at least in theory, how does it work? Very high energy of ultra-short bursts that leads to pores formation in the sarcolemmal membrane, and if the electrical field is large enough, those pores results in leakage that leads to cell death, either by apoptosis, necrosis, which is irreversible. Now, Jacob Koruth, which was the first speaker in this session, beautifully and for the first time showed the effect of PFA using the flower catheter, the Farapulse Boston Scientific now catheter in the ventricle. And you're going to see atrial cases with this catheter today, and it's being used in Europe now commercially. But this is the result of applying endocardial ablation with this catheter. And you can see that it makes very well demarcated lesions, and particularly in the relatively thin right ventricle, that can lead to transmural lesions. Okay, so at least in healthy tissue, it looks like it can create good lesions. Now, this is a study from our lab, one of our fellows that used the Affera sphere catheter that you saw yesterday and you'll see later today to perform a PFA in healthy tissue. And what this study adds to what Jacob reported is that while applying one lesion of PFA, one lesion, I mean like the whole train, but one lesion of 4 or 5 seconds results in a lesion size of this sort, let's say 1x. If you repeat it, you do like 4 times, 4 ablations, one after the other, it results in larger lesion and deeper lesion. And that's something that is not what we see with RF. With RF, you make a lesion, you repeat the lesion, you're unlikely to get better penetration because the heat actually you're probably going to get less because of the edema. With PFA, the way that it works, think about it. What we do, we increase the permeability of the membrane. So every time that we apply an electrical field, we create more pores and more pores in the membrane, right? So the conductivity of the tissue increases. So the next pulse that comes meets like a higher conductive tissue. So it penetrates deeper and deeper and deeper. Now, I'm sure there is some plateau to this, but at least at 4 lesions, one after the other, that resulted in increased permeability and increased lesion formation. Now, the other thing is that PFA may be more effective for targeting scar tissue, and that's, I think, the point that we're trying to figure out. Is PFA have any preferential advantage for ablating in scar? And I don't know, but I'm going to share with you some original data that I haven't shown before. Now, the idea for this, or at least the hypothesis why PFA may work better in scar is that there is a low electrical impedance in scar compared to the normal impedance. So here, this is an infarct that was done, distal LAD infarction, in, I think it was like in a swine model. And they measured impedances in this chamber. This is 1 week after the infarction. And you can see in the bold black numbers here, the impedance is a little bit lower compared to the uninfarcted myocardium. But if you remap this chamber 6 weeks after the infarction, you can see that the impedance is almost half. You can see numbers of 60 and 70 compared to 120, 140. Now, why is this important? From the same reason that I explained in the previous slide, if you have increased permeability of the tissue, so the electrical field can penetrate, can reach farther, and that leads to increased loss of surviving cells. So in theory, PFA may be more effective in scar tissue compared to RFA, which actually going to be less effective in scar tissue because it's limited by the collagen that creates a thermal barrier, right? So I'm going to share with you this work, and the aim of this was to examine the effect of PFA on a heterogeneous ventricular scar in a preclinical model of healed myocardial infarction, and this is the model we have. So we inflate a balloon in the LAD, just past the first diagonal branch. We survived the animal, and we did multiple MRIs on this one when we developed this model many years ago, and we figured out that 8 to 10 weeks results in nearly healed infarct. And how do we know that it's nearly healed? Because we see here on the right, it's a very heterogeneous scar with surviving bundles along with collagen and fatty infiltrate, but you also have calcifications. You have multiple calcifications throughout like this remodeled ventricle, what we see with patients years after infarction. So it's relatively mature. Obviously, it's not mature like a scar that has been there for many years, but at least it's a model for us to evaluate the effect of different energy sources. And we use again, the Sphere 9 catheter that can deliver both RFA and PFA. In the previous study, I showed you, actually I did not show you this, but initially we did study this with RFA. Here it's only PFA, so we're only using PFA and investigating its effect in scar tissue. So we took 4 swine, we performed ablation in border zones. Border zones were defined as areas with gradients of voltage. We wanted to look in areas that the voltage was 0.5 to 1.5, and we looked for abnormal discontinuous electrograms. So we knew that there is live myocardium there, but it's disrupted. We also paced there to make sure that we can capture, and we recorded electrograms before and after ablations. Now, we did PFA ablation with the same sequence that I showed you last time. We repeated this 4 times because we said 4 times work better than 1 time. Let's try 4 times. And we survived the animal for 48 hours so we can appreciate the full effect of PFA. This is just to show you how it was done. So this is, in this case, I'll play it again. This is the infarct with actually an aneurysm here, thinning an aneurysm in the anterior septum wall. And this is the sphere catheter that it's echogenic, and you can see this on ice, touching the tissue very nicely. Now, the control group were 4 swine. Actually, I'm sorry, it's 5 swine here, doesn't matter. But these are swine that underwent a similar infarct. They were mapped with, the chamber was mapped with pentarase, so we could define the border zone of the infarct. And we performed ablation with STSF. And we used these parameters, 30 watts, contact force 15 to 20 grams. And we chose an ablation index here. Although ablation index is not really validated for the ventricle, but we use 600 to 800. The reason being is that we've done a lot of studies that we're going to publish soon showing that after 600-700, there's no more effect. So 600-700, you maximize your lesion, there's no much more. And usually that can be like a minute or a minute and a half. So it's also like a good, a good duration of lesion. And these are the results. So the animals were survived in both groups to about 8 weeks. The volume of the ventricle was relatively the same. We performed 11 applications in 4 swine. The reason for 11 applications is that we wanted to make sure that we are really have separate lesions, they don't merge with one another, and that we can recognize them. Typically, those chambers, they are not big enough to apply too many lesions, and one overlap the other. It's going to be very hard to do an analysis. What we found is that when you see, this is an example of lava potentials, of fractionated high-frequency potentials. After the first application of PFA, the near-field electrograms completely disappeared. And we lost capture. This is capture before ablation, loss of capture after ablation. This is from the PFA group. In the RFA group, we did 12 applications in 5 swine. Again, ablation index 600 to 800. And the ablation duration, or the contact force, the mean contact force was 19, ablation duration 75 seconds. So these are good lesions. And we gave TTC before sacrificing the animal. And when the lesions had what we expect to see a spheroid shape, we could also calculate the volume from this by using the formula for half of an ellipse. And I would just want to show you how those things looked like. So this is an example of 4 PFA lesions. This is like we opened the left ventricle, and you looking from the free wall into the septum. This is the septum of the left ventricle. And you can see 4 lesions. The white one is hard to appreciate because it's folded a little bit, but at least you can see 3 that are really well demarcated, marked with those pins. I cut through one of those lesions here, the yellow one, and you can see how the scar from the infarct, extends from both sides, laterally from both sides of this lesion, but the lesion, at least here, and I'll show you the histology, looks completely transmural. On the right panel, you can see a lesion created by a thermocool catheter. What we usually see, it's like this small pinpoint dimple here. As the size of the catheter is much smaller, and that resulted in some more demarcated than I expected lesion in scar. Now let's just try to understand those histologies. So here you can see this is the gross pathology of this lesion. So the catheter is sitting here, somewhere here. I can't be accurate because I don't know, but it's on the endocardial side in this border zone. And the lesion size here is 9 millimeter, which is the surface lesion size is 9 millimeter, the size of the catheter. And you can see the subendocardium, which in an infarct, that's a subendocardial surviving layer. And everything that you see marked in the dotted green line, these are areas that have irreversible injury from PFA, and all of this work, by the way, all the histology was done by an expert pathologist. So those cells are, all the area under the catheter is ablated. the blue is the fibrosis from the infarct, but see what happens. Distal or deeper to the fibrosis layer, you also have a big area that underwent irreversible injury. And on the side, you see the healthy myocardium. So what PFA did that, and I'll show you the RFA did not do, but that's we know from all studies, is that PFA was able to penetrate through a fairly thick layer of fibrosis to produce a lesion or to kill viable myocardium deeper to the fibrotic layer. Now, this is another example, and this is what you see. This is like a classic post-infarction scar. You have subendocardial preservation of tissue. That's what gives us the VTs, particularly those endocardial VTs in ischemic patients. And then you have like this deep, deeper scar that is can be almost transmural, just sparing the endocardium. In this case, you can see so the lesion completely eliminated the endocardial layer of cardiomyocytes. But see what happens here. Through the epicardium, you see three blood vessels here. You see, two blood vessels, a vein, an artery and a vein, and another area here of surviving sleeve of muscles in the subepicardial layer of this infarct. But what happens? PFA penetrated and killed all of those cardiomyocytes, preserving the cytoskeleton of the arteries. And this is, in comparison, the healthy myocardium. Now, if we zoom in here, these are contraction bands all around it. These cells are completely gone. They are not going to recover, but the blood vessels are recovered. And this is way deeper than when we applied the energy. We applied the energy endocardially. The electrical field passed the collagen to reach the subepicardium and ablated viable myocardium there. This is an example of nerves. These are nerves tissue within the collagen. The nerves are not affected by PFA. This is what we expect to see. That's what Jacob showed and others showed in the atrium. And this is another example of a PFA lesion. See, all of this area is an area of a dead subendocardial layer with contraction bands. Big fibrosis, nearly the entire thickness is fibrosed. Boom, you have a surviving layer in the in the epicardial layer, subepicardium, and intramurally. And what happened to this? Affected irreversibly by electroporation. Now, in comparison, this is from the RFA group. This is what we expect to find with RFA. So on the in the green dotted line here, designed line, you can see the contraction band and the cells that died from thermal injury. But in the red dotted line, within these areas, you can see the healthy myocardium. And you can see that you have healthy myocardium obviously deeper to epicardially to the epicardial side of this lesion, on the edges of this lesion, and the lesion is limited to just under the catheter, where everything else is being barriered or being insulated by the scar. What about lesion dimension? Let me just show all of this. So the depth of the lesion was bigger with PFA compared to RFA. Now, obviously, the depth of the lesion is dependent on the wall thickness. You know, the wall thickness may be different. So even if you try to correct the depth of the lesion to the wall that it was ablated on, still the PFA penetrated more percentage of the wall thickness compared to RFA. Width was larger, but I think the width was larger also because this is a bigger catheter. And the frequency of reaching transmurality was also significantly higher with PFA compared to RFA. So to summarize, PFA may be a promising technology for ablation of ventricular arrhythmias. It creates well-demarcated lesions in both healthy and scarred myocardium. It's able to eliminate viable myocardium deeper to the thermal barrier created by collagen. I think that's the key point. PFA lesion dimensions exhibit repetition dependency, as I showed you from the previous work. So repeating a lesion as opposed to, or in contrast to RFA, will increase the lesion size, including its depth. So it makes sense to repeat it. However, there is more work that is needed. This is just like a very early preclinical evaluation of this technology. So energy optimization, how many times we have to repeat it, how many, what interval between applications, what's the safety profile? We saw the data about vasospasm of coronary arteries, what's the mechanism, is it safe, is it not safe? So all of this needs to be further evaluated, including the effect on ablation in the epicardium. So I'll end here, and thank you very much.
Next speaker is the Dr. Ante from Splint. He's talking about the load of the pulse field in non-PV ablation in AF.
Hello everyone,
Yeah.
my name is Ante. I come from Split, Croatia, and my role today is to talk on pulse field ablation in non-pulmonary vein ablation in AF patients. These are my conflicts of interest. When I think about failures that we see with AF ablation today, I think that historically one of the most important reasons are imperfect ways to check for PVI, but we have to understand that throughout these years, we're not able to recognize the right substrate for a given patient, and this is the biggest frustration, I think, in our community. And we have to understand that all those studies that tested some beyond PVI lesion set had almost zero info about lesion set durability, and the fallacy of these trials, I think, is mostly due to I would say, poor lesion set durability. Today, when we talk about how to approach non-PVI responders for persistent AF ablation, and we all had high hopes on an individual's approach, scar ablation, whatever, and we're all reluctant to believe that empirical lesion set will work. Actually, today in 2022, we have to confess that empirical lesion sets are more promising than individual's approach at this moment. Two most promising empirical strategies at this point of time for AF control in non-PVI responders would be, as I perceive, the Marshall Plan, developed by the Portugal group. It consists of on-global ablation of William and Marshall, and then they go for PVI, linear ablation. It usually consists of roof line, mitral line touch-up after William Marshall ablation, and CTI. And there's another proposal for the box lesion, posterior box lesion, where you do PVI and then ablate or isolate posterior wall. What makes pulse field ablation suitable for this quest is the energy delivery is really short. Also, overall short application time is typical for the PFA. It's safe to work collateral structures while having preserved potential for the lesion transmurality. And there's a different post-ablation healing process, and I believe that this different type of fibrosis that preserves the reservoir and conduct function, and it has less early proteogenic potential because less inflammation can be also a differentiator when comparing the older techniques. This is not a fairy tale. There are downsides. There are some limitations. Energy source specific limitation would be that I really don't recommend the application of PFA in vicinity to the conduction system, sinus node, baby node. Clinical significant coronary artery spasm can occur and has been well described for mitral ablation and also for the CDI. An increased number of applications may lead to increased embolic potential that otherwise we don't see for the basic lesion set for PVI. But when you pack more and more application, these microbubbles might coalesce. Their red cell electrofusion is also a phenomenon that has been well described and may increase the number of embolic footprints. There are some catheter design specific limitations. I think there are single shot designs that we have nowadays are not suitable for focal substrates or like mitral or cardiac ablation. And focal PFA is well suited for everything, but it takes time and hard skills. So don't expect your fellow to be accomplishing this task tomorrow or any day after they start. This is the landscape. So all the market leaders and are really investing and developing their own platforms, mostly single shot. And there's plethora of startup companies trying to get their market share and develop their own ideas, how to some new catheter designs with proprietary mapping systems, and some are developing focal solid tip ablation. Let's go target by target. I think we should waste most time on posterior wall. We talk about linear ablation. I'll touch bases and also the left atrial appendage dilation. And you imagine that with the time, any other substrate will be reachable with this technology. When I think of posterior wall, I think it's most important thing is the site, so-called the Persephone trial. It is the only PFA trial with the pre-specified lesion set in a short-standing persistent patient. What we did in this trial is that after we executed the regular PVI procedure with a Faraday catheter with Therapulse platform, we would drive Faraday catheter toward posterior wall, and then we would ablate directly posterior wall, overlapping our lesions, so to make homogeneous box lesion. And during ablation, we lack the concern about esophageal safety because it's and we are taking advantage of this discriminatory nature of this this energy source. Overall, 24 patients in this trial were treated with posterior wall ablation. This is how you see on a mapping system. The Faraday catheter is represented like a large lasso, 35 millimeter in diameter. And the most important thing is that it only takes around 10 minutes to execute this lesion set. And this is ideally, this is your final result. And in my career, I never seen such a potent anti-fibrillatory lesion set like this one, completed homogeneous box lesion PVI and posterior wall being electrically silent. The success rate at 1 year in the Persephone trial, 92% were free from any atrial arrhythmias. I have to say that 9 had received touch-up ablation remap, but only three for the PVI, and 0 patient had conduction through the posterior wall. So all the rest received mostly CTI or some other linear ablation in this group. What about safety aspects of the rather extensive lesion set? Well, in Persephone trial, we didn't have any instance of phrenic nerve injury, no stroke TRA, no Pfa stenosis, and no esophageal complication. The single complication that occurred was actually in a patient who received RF only at the remap procedure. Our team published recently an ERA and presented an ERA poster where we expanded and we do the pooled analysis of 3 different trials. 72 patients were enrolled in 3 different PFA first in human trials with a prospective GI endoscopy, upper GI endoscopy performed between 24 and 72 hours after the procedure, and we had zero gastrointestinal complications. Further on, we recently we showed a continued experience with posterior wall ablation with a Therapulse platform in resistant atrial fibrillation patient. Significant number of patients had long-standing persistent, many of them previous ablation, and it took around 10 minutes to ablate posterior wall, and no safety inputs occur in any of these patients. This is very promising. Of course, it's very little to ask. What about FTHM after this kind of ablation? What about function? And this is our own data. Patients served as their own controls. So strain, left atrial echo strain analysis, pre and 3 months post. Reservoir function and conduit function are preserved 3 months post. Of course, contractile function is a bit reduced. And this data is corroborated also with MRI data published in a Europe-based last year from Bordeaux group. Recently, Vivek Reddy showed the late breaker in ERA, Manifest PF trial. Actually, it's a post-approval period with the therapies, almost 1,800 patients, 24 European centers performed these procedures between March 2021 and January 2022. Significant proportion of patients were resistant. In 6%, they received also posterior wall ablation, and acutely PVI was successful in all. The most important aspect of this manifest PF is to say that though this is very initial experience post CMARC, the complication rate is completely in line with the current technologies. And there's no reason to suspect that we should be able in the future or distant future, but one day we'll be able to accomplish this lesion set also with other single-shot catheter designs. Medtronic is testing its pulse ablation platform in the PulseSafe trial, Biosense in the Inspire trial. These are both repurposed RF catheters, but I think they will work good. Eventually, the teams will find a way how to make durable PFA lesions. Another way how to accomplish this is to not develop your own platform, a new catheter design, as yet to you see here. This is a Galaxy team with us, and we performed what we call true focal PFA. And the investigational device is this funny-looking piece of hardware. This is PFA generator, and you connect this PFA generator to your favorite ablation catheter, to your favorite mapping system. You can use contact force sending catheter, and we tested it with all three widespread systems, so Navix, Cardo, and Arrhythmia. And this is a case where we had the patient who could not cardiovert after PVI, so we wanted to isolate the posterior wall, so we made lines, upper and lower line posterior wall. Of course, this map looks exactly the same like after direct application. There's a box here, but you see here that we have a AG grid over the posterior wall, and now we paste AG grid, and you will see that we are capturing the posterior wall, and it's blocked toward the atrium. So it means that we preserve this tissue. We did not ablate this tissue. This tissue is isolated. Talking about linear pulse field ablation, I think focal PFA drilled through a solid tip contact force sending catheter will be the first choice in the foreseeable future. Other catheter designs will be also effective. Pfa is coming, and they have CMARC, and they have outstanding results, very pleasing results. However, yet to be seen how what about generalizability of this data when it comes to widespread adoption or across the US centers. We also had initial experience with the Therapulse large focal catheter. We called it Flareflex. It did outstandingly well in the CTI ablation, yet to be shown. I think that the lack of contact force sensing at this point of time is downside of this catheter designs. Also, the lesion depth. If you do just biphasic, bipolar is not enough for some points or some locations. This is a nice case of a typical thyroid ablation with focal PFA. Just wanted to say how we control this. So you see we are finishing the roof line here. We are just putting dot, and you will see here the roof line flutter. We initiate PFA for this last dot connecting the roof line. We get rid of roof flutter, so we already know how to control this energy, and obviously this is also saying that all these lesions were affected before. Few words about left atrial appendage isolation. There are no prospective data from clinical trials. We have anecdotal experience with the Therapulse platform, 5 patients treated so far at our center, and in all, left atrial appendage was concomitant to the closure procedure. Usually we apply 8 to 10 applications, mostly in flower conformation to avoid PFA, the landing zone for occluder. And actually we were successful in all patients so far. Of course, phrenic stimulation happens during delivery. You have to take care of. Fortunately, we didn't have any signs of coronary artery spasm here. You will see here that during application, you do have phrenic nerve stimulation. You want to take care about your wire. I'll say you don't want it to be too deep in the appendage. And here you see that we are applying in a basket conformation because osteo was not that huge, so we could isolate the appendages at a very osteo level. This is a very specific patient, older lady, and she was referred for the airway closure procedure, but also she wanted the AF control. So we did PVI, we did posterior wall ablation, we did left atrial appendage dilation, and we tried to convert her. When converted, she started with the ATAC, and we mapped ATAC with a HDV catheter, where we realized that there is a critical isthmus in the anterior left atrial wall. And when we went there, also with the Therapos catheter, we were able also to record this funny, long-lasting, fractionated electrograms consistent with the critical isthmus, and a single PFA application got rid of flutter here. So this is future, and we'll see where we come from here. My conclusion is that when I think of the roles of pulsed field ablation and non-pulsed field ablation in AF, I have to say that PFA will likely cut down the procedural time for beyond PVI strategies. Posterior wall ablation or isolation with PFA is quick, it's safe, most likely will result in improved outcomes in short-standing persistent AF or PVI alone. This is yet to be proved, but it's my strong feeling at this point. And linear ablation with PFA is definitely feasible, likely to replace RF in the near future for lesion sets like roofline, mitral, or tricuspid isthmus ablation. And I think solid tip or large folded catheter designs will likely prevail for these strategies over some kind of single shot designs. With this, I conclude and I await your questions. Thank you.
So the next talk from Dr. Petr Neužil. He's going to talk about the focal pulse field ablation and non-contact mappings. Petr, please.
You should connect directly from Homolka Hospital.
Hiroshi and Joseph,
Yeah.
All right.
can you hear me, right?
So we can even see you.
Yes.
That's perfect, okay.
Lovely green.
Okay, so I made the presentation shorter because I need to save time for discussion. So the non-contact mapping I will be speaking about, you are very familiar because it's Acutus-based non-contact mapping system, but they implement the focal pulse field ablation capability to the system. There are my disclosures, and actually you are pretty much familiar with this mapping system with the 48 ultrasound transducers basket, which create a very fast way the anatomy, which should be very stable in terms of the procedure control. And then on top of that, there are 48 electrodes taking the single shoot and the single pulse activation. And the basket itself is 25 millimeters, and actually in Europe, I'm very familiar with this, so I don't want to go to the more details than that. Actually, this high density with resolution less than 2 millimeters, and the ultrasound, after ultrasound creating anatomy, you can just map all this very fast activation. The original purpose was just create, the activation of the rotor, rotor cycle activation, and then single, as I told you, so single pulse activation, and acquire this single pulse activation to the map. On top of this mapping system, the engineers from the company introduced the pulse field catheter, which is focal pulse field catheter. And actually, when you review all these talks from today, actually there's a strong movement towards the pulse field from very, very logical arguments, because it's not only fast, it's tissue selective, it's a non-thermal, and because of non-thermal, it's really preserve all the collateral structures and creates no PV stenosis. We have a lot of arguments supporting this finding. The catheter itself is the golden tip irrigated catheter with 3D optical contact force sensor, and actually with this catheter we are all familiar, and it fits because it's 8 French deflectable catheter. It fits to very obvious sheets, and we are very familiar with the mapping capacity. So itself, the catheter is combined for RF application and pulse field as well. So speaking about the pulse field application for this contact force catheter, this is biphasic and bipolar. The company is working on unipolar catheter right now, and we did some preliminary patient series, but I would like to speak about biphasic bipolar, which based on preclinical data, we used 3 pulses with 1750 volts dosing, and in the pulse, I mean, duration is like microseconds. The pulses are really gated to the atrial electrograms, and you can use even atrial pacing during the sinus rhythm. Actually, you can, as an operator, you can choose how many pulses you want, so you can choose 1 pulse, single pulse, 3 pulses. But based on the preclinical, as I started to explain, so we confirmed that the lesion depth with the focal catheter with 3 pulses, with that kind of voltage setting, is around 4-5 millimeters. With unipolar, you can create even deeper lesion. So what is advantage from this optical contact force capability is that you have not only the contact force information, you can use even the orientation of the catheter, which is really important when you want to see actually the catheter perpendicular and then tangential and, I mean, parallel to the tissue, because remember, this is a bipolar, means that it's going, the pulse going from the distal to proximal. Based on that, you can even influence the lesion depth. Okay, and actually based on this information, then, and I will show you during the recorded case, you can even show on the map the, I mean, integral and actually continuous lesion formation. As I started to speak about preclinical results, this is some specimen from 14 days animal, which is the section was done 14 days after first applications. So there are like right atrium specimen, and this is like 4 applications. And you can clearly see that coronary vessels and all the structures are really preserved, and it's a very intact and no any thrombi formation, and it's really transmural continuous lesion. When it is the same specimen from histology, and there are intact vessels, there are really transmural lesion, very solid, very smooth lesion. We started, as I explained, so we started the first in-man trials. This is a CE study for PFA CE mark study. So it's a de novo atrial fibrillation patient. PV isolation is the main step for the performance of ablation, but actually even the lesions and linear lesions are allowed to apply when is needed. The follow-up is 90 days, and we have for all patients and in the other procedure for remapping procedure to see the lesion formation after this 90 days, and the follow-up is like 1 year. So together we did up to now 24 patients. 14 patients were done by bipolar, and 9 patients were done by unipolar application. This is one example, and this is, I hope that the last picture for my presentation. The I mean, the picture of contact mapping is like non-contact. Contact is the system can allow you to map contact and non-contact. So after the PV isolation with PFA, the single PAC from right side veins, and you can clearly see by single shoot, by single activation map, that actually the activation stopped really on the border of the ablation line. So actually with this picture, and you can see here, so it stopped and preserved from activation. So with this picture, I will stop my presentation, and I hope that we have still some time for discussion. Thank you.
Well, thank you very much for this presentation, and this basically closes our pre-recorded or live session, lectures. And we have time for discussion about half an hour. So any questions to any of the presenters?
Thank you very much. Question to Elad. Elad, really impressive findings of PFA in the ventricle. Just a couple of questions. Firstly, do you think the 9mm lattice catheter is ideal for all areas within the left ventricle? We have trabeculations, moderator bands. Do you think there are other catheter designs will be useful in the ventricle? And my second part is, not all VTs in the ventricle are scar dependent. Certain VTs are dependent on the conduction system. We may want to target fascicles or Purkinje fibers, and do you think PFA has a role there?
Is a lot connected? Well, if not, in the meantime, I can answer.
I can answer that question.
About the maneuverability in the ventricle. We have some experience with the RF using the same catheter sphere, and it works pretty well because it's a relatively soft and it's a relatively rough surface, so it stays where you put it, so it's not sliding, and you can adjust contact, and maneuverability is the same like with thermocool, so we had no problem to maneuver across the left ventricle or right ventricle. I think that's definitely a good catheter for ventricular application. And the other question was? Conduction system. I think the conduction system is just underneath the surface, so you don't need this weapon probably. So I still believe that many applications will be done still with RF, like AVNRT ablation or conduction fascicular VT ablations. It's more about mapping, and then the ablation is relatively easy. But for deep substrate, even if it's sort of focal arrhythmia, like in the summit, I believe then it could be helpful, as we all know. So this will, I think, come within next couple of years. We will find some proper indications for each catheter design or each platform, because every platform is different, as we could hear. It's completely different from RF. It's important to realize that you cannot talk about pulse field as one entity which works in all different platforms in the same way. So it's very much, as you could hear in these nice lectures, is very much dependent on design of the catheter, on configuration of pulse. There are too many options, and we need to learn more, but it's clear that it is very exciting. Everybody who had the opportunity to work with this technology, I think, is really very pleased and very enthusiastic, I would say.
So when we are speaking about sphere 9 catheter and an VT application, we recognize that, for example, the VT originating from papillary muscle and the sphere 9 catheter is absolutely fantastic to fit this because of stable formation of the lesion. So actually, well, for VT, I hope that when we can improve the transmorality, I hope that it will be ideal for VTs. And on top of that, if we can guarantee the depth of the lesion, we can speculate if we really need epicardial applications. So this is the most critical part of my thinking about pulse field.
To answer that question about trabeculation, I think one of the beautiful things about a large tip catheter with PFA is that the challenges that focal catheters face with trabeculation are completely solved because it ablates everything within the vicinity. So for things like moderator band, as long as you have reasonable contact with large tip catheters, you will likely be able to ablate these targets much better than a focal catheter that's very, very dependent on good contact.
I would not be so much obsessed with transmurality in ventricle because many of these substrates are subendocardial or intramural, so you don't need to really ablate across the whole ventricular thickness. But it's important also to emphasize that this sphere 9 catheter from Pfa can use also high energy RF, and we did some ablations as you did, Petr, of VT in structural heart disease with this catheter, and it has a very large footprint. And if you read the paper by Elad Ante, which was published recently on this experimental use of pulse field, he has a graph comparing the size of the lesion, and with this lattice electrode and high energy RF, you can have a lesion which is around 1 centimeter in diameter, which is a really large lesion, which can cover very nicely the substrate very quickly and very safely, seems to be. But we need definitely more experience with this. So that would be beauty of this system, that you can toggle between RF and pulse field. Any other question, comments, please? I have to look if there is nothing in chat now. Everybody is either astonished by what you heard, or does not believe, or.
Yeah, I have a question, please. To Mr. Nakagawa, you said that the lesion, the irreversible lesion of the PFA, it's like on your slides was like twice as big as the reversible one. So it's my question now about this sphere 9 catheter. Does it mean that maybe these lesions will shrink with time, or is this irreversible reversible lesion much more bigger than this 2 centimeter which I've said right now?
Okay. Let me answer the question. Make a long story short, for example, the regular focal RF catheter, 4 millimeter tip, second, third, fourth electrode. From the tip of this ablation electrode, number 4 electrode, like a 14 millimeter, right? Then first pulse field application from a tip electrode. First pulse application, all electron up to the number 4 electrode, all gone. So it means so therefore the lattice 14 millimeter, diameter 28 millimeter, approximately 3 centimeter area, electron is gone acutely. And the waiting 1 hour doesn't come back. And then we waited for 2 weeks, animal model. And then we do the historic examination, lesion diameter, maybe like 5-6 millimeters. Okay? So so that's reality. Even the Pfa lattice electrode, clinical setting, first application, let's say around the PV entrance, first shot PF, you eliminate entire potential from the lattice electrode. If you go next spot, already it's gone. You don't see anymore. My concern, we might lose the ability for the electron-guided mapping ablation by doing PF application. And also, termination ATBT might become the more less specific. Of course, you need to terminate tachycardia. However, the affecting broad area standard myocardium, again, because applying a high voltage membrane permeability myocyte change. So therefore, very easy to produce the conduction block. But again, the pulse field application initiate the reversible electroporation. Unfortunately, membrane repair come back. That's people doing a gene transfer. Good news, easy to eliminate potential, but make bad news, the may not be durable lesion. So eventually, we might need ablation index. I'm working on right now, so that's my answer.
If I can add something, yeah, that's true. But on the other hand, we have remapping data after 3 months with several platforms, at least with Pfa or with Farapulse, and you see that the lesions are really durable and there is isolation. So that does not mean that you should not go around and really overlap the lesions, for instance, with Pfa, because that makes sure that you have really continuous lesion set, because signals disappear very quickly. So you cannot judge by signals, but you have to really go around. But it seems to work also without mapping system. We just do this flower and you rotate a little bit and it works in the same way. So I think really it is very powerful, and I believe that this is a game changer compared to all previous technologies.
I mean, I agree Joseph or partially disagree. I mentioned Pfa, that's to 9 millimeter, but each ablation site, ablation tag only 7 millimeter. We're connecting, we're making a tremendous overlap. So that's I'm saying the first ablation avoids potential. Next, not ablation site, already potential gone. Regardless, we are ablating, we're connecting. We're very serious connecting ablation tag. Even the like a circular catheter, you eliminate the all PV potential, even fast pass, but after that, go to nose, north, west, east, south, ablating. Then go to next vein. So by doing a multiple application, the follow-up data, actually encouraging, but if you just stop it, fast pass, no electron, and then nobody doing the clinical follow-up study, not stopping acute procedure like that, right? So the reason, the good durable lesion because multiple application or more overlap. I don't know Peter, how do you think? Peter, any comments? Do you hear me? Hello?
Yeah, I can hear you. I can hear Hiroshi. So, you know what? I will answer by question, okay? For you, both of you, okay? Hiroshi and Joseph. After all information we have now, and Joseph is very experienced with the pulse field. So after all good we heard, okay? Fast procedure, durable lesions, safety, and selectivity. What would you expect as a bad news which could stop this application?
Not enough
would you expect
resources
even
to
some
produce
bad
catheters.
news?
That would be the only, in my opinion, the only barrier for more widespread use of this technology. If companies cannot produce because of some reasons, like you have now crisis and different...
I'm wondering that actually how long we studied the RF, okay? It's like 20 years we spent to study RF, and in I mean, 5-6 years, we have so many information about pulse field, and so I'm still looking when it's something so excellent, so nice, so perfect. Okay, so I'm still looking what can stop me to do that. Right?
Well,
Can I make some comments? We should be having a publication coming out soon, but in the ventricle, the challenges that I think PFA will have is one of the biggest challenges is we do so much VT work based on entrainment, slowing of tachycardia, termination, reinducibility. But with PFA, one of the challenges we'll face is that once we map and burn, or sort of ablate, we won't be able to interrogate the tissue electrically like we did with RF. And that is why we'll be so dependent on knowing what the depth and contact and what kind of lesion to expect. So I think that's going to be a big negative if PFA is used for VT. It doesn't mean that it won't work. That's one issue. Another challenge with PFA that we have demonstrated, hopefully you guys get to read that soon, is that PFA actually activates myocardium. So when you're ablating VT, you may just terminate the VT from the electrical activation of PFA and not because you broke the VT like with RF, where you're actually affecting the isthmus. That, the issue of vasospasm when you're on the epicardium, the issue of potentially sparing Purkinje fibers, which are important in ischemic and VF triggers, these are all things that may take away from some of the effectiveness of PF. So like Joseph and everybody else is saying, the ability to use both RF and PF would give a very good opportunity to bring out the best of both these technologies in VTs.
There is one question here. Okay.
I'm Jarni Štublar from Ljubljana, Slovenia. I have to congratulate you for the really interesting session. I have maybe a question for all of you regarding the Professor Nakagawa. He mentioned that even after 1 hour, there are still signals are gone. What duration you implement in your clinical or preclinical work for the acute success? So how long do you wait after the PFA applications?
Okay, let me start the answer. Make a long story short, I don't know yet. And then nobody wants to wait more than 1 hour. All clinical protocols saying 20 minutes, right? And then we did a preclinical swine study. We waited 4 hours, still no potential. I don't know after 4 hours and up to 2 weeks. So therefore, to be honest, the acute endpoint for the procedure, first of all, electron elimination, we need it, but doesn't, not very, specific at this moment, unfortunately. So good answer and a good question, but I don't have answer. Thank you.
It's very important to remap, for instance, after 3 months, because that gives you immediately the clue whether it's working or not, what is durability of lesions, and it seems to be very good. So rather than waiting 1 hour or more, we have also experienced that will be discussed tomorrow, how it will influence GPs, for instance. And it's, we know that it's just transient, but it will be discussed tomorrow, so I don't want to go into this topic because then they have nothing to discuss, Hiroshi and Petr tomorrow. So wait until tomorrow and you will have answer also for this topic. So there is one question here.
Yeah, also
Ante?
Yeah, hi. I just want to help and answer this question by one clinical observation. We had around more than 100 patients treated in the clinical protocols with the PFA. We never observed AF recurrence within the first 24 hours. We did some after 4 to 5 days. And coming back to the old days when we had bed RF experience, and you would see a lot of recurrences even on the ward within the first 24 hours. So maybe this goes together what Professor Nakagawa had told. There's no sense in waiting for the electrograms to reappear or the stunned tissue to recover. It does not recover. It seems does not recover in the first 24 hours. So this is a part of the game. So we are losing our standard protocols, waiting, and we don't know what the adenosine challenge will do. So that's why you need good preclinical data, good data from the trials, and the best practice should be used to avoid reconnections or recoveries.
Yes, thank you. I have a practical question. How painful is this technology for the patients? Is the same for all of them? Do you need always general anesthesia? You can perform with soft technology deep sedation?
Yeah, we started to use propofol just for a very short general anesthesia, without anesthesiologists, obviously. So, yeah, it can be done, but it's sometimes they feel spasms and it's painful, or they are coughing. So you need some general anesthesia, but for a short period of time. So you can handle it just with propofol, or in a deep sedation plus propofol on top of it. We do now these cases for workshop. We do in general anesthesia with anesthesiologists, because that's also good for patient during such a life case. It's prolonged, so this is the reason. But generally, it can be done without anesthesiologist.
I add something, Peppo. I completely agree with your comment. So we are studying to do the cases probably since 2019, 2018, without using any general anesthesia. And as a general practice, we started to use Pfa since April 2021. And since then, we did over 800 patients. And I would say that actually you don't need any general anesthesia when you have experienced nurses and experienced doctor to put just really deep anesthesia, deep sedation, just for temporary application. Because if you consider, PVI, it really lasts just like several minutes, okay, several minutes. So for this irritation, because there is some activation, like coughing, as you mentioned, coughing, musculature irritation, and it's temporary. So it's really for this temporary and really intermittent activation, you can deal with deep sedation.
Any other question, please, or comment?
I have a question.
Okay.
My question is about the using the focal PFA and for ablation of the small focal targets like accessory pathways, for example. Do you see any role in this? I know it's more of the matter of mapping, as you said, but will PFA bring more safety in ablating, like in coronary sinus, for example, or in pediatric patients where it's crucial to avoid the collateral damage of the coronary arteries, for example? And will it be possible, and will you use focal PFA in very close to the AV node, for example, or parahesian accessory pathways, for example?
Well, I don't have experience really with a focal catheter like Petr, but I have only experience with Pfa. But I don't think I would use it close to AV node or for just a normal accessory pathway ablation, because that's more about mapping, and with RF you can do one application, so why to bother with pulse field and do some more unpredictable, maybe even a lesion or more destruction of the tissue. But Petr, can you respond? Did you hear the...
Actually, yeah. Okay, so thank you. So Ante is first, but as I can comment, we didn't try, okay, we didn't try. But I would say with the reversible pulse, you can be very close to AV node with reversible pulse. But the problem is to set up the reversible pulse. And you need to be sure that you apply a reversible pulse. And then if we can use the reversible pulse for all this, regular arrhythmias, like you said, like SVTs, accessory pathways, AV node ablation, or even SA ablation in the sinus node. So actually, I think that it will be really, really helpful for us to use focal catheter, focal application. So I completely agree that we need to deal with that. So Ante, do you have some comments for that?
Yeah, thank you, Petr. Just to add, I really believe that the left lateral accessory pathways will be amenable to ablation with a focal PFA through solid tip catheter. But we have, and then the other aspect is, what about these parahistine accessory pathways? What about substrates close to the conduction system? Conduction system is extremely sensitive to PFA. And I'm not sure that we are getting close, or even close, to this idea of putting reversible pulse. Well, that means the low output. And then if you go to the therapeutical pulse, it's likely to damage. How do you make sure that your lesion is not bigger than with your reversible pulse? So I think for the AV node structures close to AV node, we'll continue to use thermal methods. And accessory pathways, depending, ablation through the CS, doable. Coronary circumflex spasm can occur. And the question also, and this comes back to the LV summit VTs, whatever. At the beginning, we had a lot of, promises, well, we go and all around to the great cardiac vein, AIV junction, we ablate there. Yeah, but there are several tissue planes that you go through the venous wall and then the fat tissue, whatever. So we don't know what about effectiveness in that part. But actually, left lateral in a pediatric population, I think it's there. It might be a weapon of choice.
Some other question? Anybody from the faculty wants to comment something? We have 4 minutes.
I can add some. Yeah, I can add something to the questions about WPW and AV node. I think one of the greatest advantages of PFA is the fact that you can use a reversible pulse to interrogate a spot before you decide to ablate. So if you're in a critical spot and you want to know whether this is where you want to ablate, whether with PF or with RF, you can apply a reversible pulse, say a redo WPW. And if the delta wave is gone and then comes back in a minute, then you have a choice what to do. And I think both PF and RF with the right design catheter would be a solution. But when you get into the coronary sinus, when you get near the AV node, I think one of the disadvantages of PF is you can't tailor or titrate the dose to effect like we could do with RF. You can't start at 1 watt and then go up to 20 watts and stop. With PF, you sort of get a all or none effect, and only preclinical data directs you as to what dose or what size of a lesion you get. So I think, you may just end up using a combination of these energy sources till we get more clinical experience as to what may be the best. With pediatrics especially, I think trying to be conservative and learning on adults may be the way to go before we start using large catheters for PF in the pediatric population.
Hello, this is Hiroshi. Talking about the PF application for the accessory pathway, at this moment, I'm not very positive. To control, just make a reversible lesion, it's very complicated. Also depends on contact force. Accessory pathway ablation using RF at areas, you record beautiful accessory pathway potential from tip ablation electrode. The best portion ablate RF finish. Don't make any reversible zone. Right now, PFA is complicated. Contact electric tissue coupling also affect the reversible, irreversible. We don't have control yet at this moment. So therefore, at this moment, you eliminate pathway conduction, but who knows the reversible, irreversible at this moment. I think it's best to focus on the mapping, record accessory pathway potential, best site, ablate RF at this moment, until you get a good control for reversible, irreversible lesion formation. But I'm not very positive at this moment. The concept is very, interesting, but we are not ready yet.
Well, I have the same opinion, and I think we have no problem with accessory pathways anymore. It's a classical electrophysiology, classical conventional ablation, and success rate is very high, complication rate very low. So, but we need tools for VT ablation, for AFib ablation to do it really fast, do it safe and efficient. And this is, I think, the role of pulse field at the moment. And then we will see later. We can play with some niche indications, but I don't think now accessory pathways are the main problem of electrophysiology.
If you have some variables of Pfa in the lab, is there any role today for RF point-by-point ablation for the PV isolation?
I think there is. I mean, you have to keep training still because it cannot be dependent probably on one technology, and it also gives you a lot of flexibility that you can do lines which are sometimes you can do mapping. So if you have tachycardia which really is dependent on some isthmus, I still feel that at the moment, unless we have really widespread use of this pulse field technology and more platforms with which enable you to do mapping and linear ablation, I think we still will do some proportion of cases point by point, because otherwise we lose also skills, and that would be bad. We need to train also people. Okay. I think it was a nice discussion. Let's go for coffee, and we restart in half an hour to see some cases in live.